So happy to be here with all of you. We have a big crowd, I think, today, and we've assembled together a very exciting, dynamic group of speakers to talk to you about the breakthroughs in lung cancer. You know, I'm now getting old, and I remember when I first started caring for patients with lung cancer, what things were like, and it's been night and day now with new drugs, new treatment modalities, and so we are here to talk to you about those things and tell you what can be done now to improve outcomes significantly from where we were even a few years ago. So our first speaker is Dr. Harvey Pass. Harvey is the Stephen E. Banner Professor of Thoracic Oncology. He's a professor of cardiothoracic surgery and vice chair for research in the Department of Cardiothoracic Surgery. From 2005 to 2021, he was the first division chief of thoracic surgery at NYU. And so, Harvey, welcome, and look forward to your talk.
Thank you, Abe, very much. We're going to talk about what's changed in surgery and why this has changed. And there's a lot of factors that have made it change. First of all, we're finding lung cancers earlier with CT screening. Many tumors are small and on the outer edge of the lung with CT screening that we find, and that lets surgeons remove less lung without lowering cure rates. But overall, it's good news because this is the mortality from lung cancer from 2014 to 2022. And as you can see, there's been a dramatic drop in the number of deaths from lung cancer, decreased smoking, certainly some influence of screening, but that's really great news. And that's because we're finding lung cancer earlier with CT screening. Many tumors are small and on the outer edge of the lung, and it lets surgeons remove less lung without lowering cure rates. And this is the results of what happens with screening. Here you see the mortality in a trial that was looking at screening versus no screening. And you see less deaths happening with the screening group than the control group. The same thing happened in the Italian study, in which you compare low-dose CT screening with control group, and you have a 58% reduced lung cancer mortality at 10 years, which is phenomenal for screening. We need more people screened. We do screening at NYU. We got to get more people to the screening centers. Now, what about surgery? How has that changed? Well, this is the traditional standard, which is a lobectomy, in which you remove a part of the lung called a lobe. Certainly, it's a proven cure. It's still best for many cancers, but sometimes more lung than necessary for these tiny tumors that we're picking up. It's almost like removing a whole branch when you only have to remove a twig. So what are some of these newer options? Well, a segmentectomy, seen here, the lung is divided in multiple segments. This is the left lung. The right lung has similar segments. So with a segmentectomy, if the tumor is here, it would be great just to remove that segment so that that segment comes out and you can save the rest of that lobe. Or you can do a non-anatomic operation. Here you dissect out the artery, the vein, and the breathing tube. A wedge does not do that, but at the same time is a smaller operation and allows you to remove the tumor using a stapler or other instruments, in which you just remove that piece of lung that has the tumor. Both are true cancer operations. They're not a biopsy, but really a segment is preferred. And these small resections save more lung, and they're now proven safe for many small early lung cancers. Who's a good candidate for these small operations like a segmentectomy? Well, like you see here, this tumor is on the outer edge of the lung, and it's at the very top of the lower portion of the lung. This is the division between the upper and the lower lobe. It's located toward the outside. It's a ground glass, which means you can see through it, so it's a less aggressive cancer. The lymph nodes look clear on the CT scan and are checked always during surgery. And the key idea here is to get the right patient with the right tumor, have a same cure, and preserve more lung. Wedge resection is even a smaller resection as far as you taking the amount of lung. You remove a small triangle of lung around the tumor, and it's often used when the tumor is very tiny or very peripheral. It's also used if the patient's breathing reserve is not very good, so it's limited. Recent evidence has supports wedge in carefully chosen early cases. The analogy is cutting out a small slice instead of a whole segment. Why does less lung removed matter? Well, randomized trials have shown that they can be as effective, these smaller operations, as a lobectomy. And here are two examples of that from Japan and from the United States, in which you compared lobectomies versus segmentectomies, the smaller operation, and you can actually see that the segmentectomies did better than the lobectomies long term. That's from Japan, but they only did segmentectomies. In the United States, they looked at lobes versus wedge and segment, and there was no difference in the long-term survival of these patients, and they did just as well. So that justifies that you can do a segment or a wedge in certain patients that are the candidates for it. You'll be better, they'll have better lung function long-term, faster recovery, and more reserve lung for the future. And you're still aiming for a complete cure. So smaller surgery isn't weaker surgery, it's tailored surgery. Well, how do we do surgery now? Well, in reality, robotic lung surgery uses small incisions and is the favorite of many surgeons, thoracic surgeons throughout the country. Certainly, it's the favorite at NYU. The surgeon controls everything. The robot does not act on its own. It's a 3D magnified view. It's a very precise instrument as far as its control, and the outcomes are similar to other minimally invasive approaches. The surgeon actually sits at a console. That console then, through the surgeon's manipulations, is controlling 4 arms of the robot, and you can see everything as it happens in the operating room in 3D. And you even can do it with 1 incision. This is the newest, smallest robot with a single port, so to speak, and you'd only have 1 incision to do all these operations. And you can see here that you can take all of these things from the uniport and put it into 1 area. This is for an assistant, but many times you don't need an assistant, and the patient only has 1 site that you're going into the chest. Let's look at just an example of what's going on here. This is a robotic operation. We are removing the lymph nodes here. You can see how you can very carefully dissect the lymph nodes, remove them as a packet, and you can actually get more lymph nodes doing this. You can also be very careful in dissecting the blood vessels. So you see the blood vessels here. You see this instrument is now dissecting to get a plane between the blood vessels and the lung parenchyma. This is the lung here. You take a stapler and divide the section between the artery and the lung so that then you can do further resection. So robotics helps surgeons to be more exact. Segmentectomy and wedge surgery require high precision, and finding tiny vessels and airways is easier with the robot, and you can get safe margins with the robot. You actually can get more lymph nodes, and you can also check many different areas of the lymph nodes and do a more complete resection. And at least at our place, a number of the patients go home the next day after this operation. The newest thing that Dr. Sabari is also going to touch on is the use of neoadjuvant therapy, especially this is treatment before the operation to make things maybe shrink or have a response so the surgery can be done, but you're operating on a tumor that has been treated. It's usually these days chemotherapy and immunotherapy, which Dr. Sabari will talk about. And the whole idea is to treat up front, get all these antigens that are present in the tumor already. If you just take out the tumor and then treat, you have less of these antigens that will help you to be recognized and treated with antibodies. Here you have a multitude of antigens. When you give the antibodies, you can get all of these taken care of if you remove the tumor, if you give the immunotherapy before and then after the operation. So the goal is to shrink the tumor, treat invisible cells early, and then now this is the standard for many stage 2 and 3 resectable cancers. Immunotherapy helps your immune system fight the cancer. Many tumors are fully destroyed by surgery, upwards of 29 to 30%, and very high response rates to the therapy and improves long-term survival chances. These are two representative studies that shows that if you compare chemoimmunotherapy to chemotherapy alone, the patients live longer and have a better survival and actually have more responses. The same happens in this study, in which a different immunotherapy was given. And you see again, the immunotherapy group is doing better than the non-immunotherapy group. It also will have certain studies that will show you that the time for a patient to recur is actually less, the event-free survival in the immunotherapy arm versus the non-immunotherapy arm. So the take-home message from at least this presentation is more patients can safely have smaller lung-saving surgery. Robotic surgery improves precision and recovery. Chemoimmunotherapy before surgery boosts response rates to therapy and cure rates. Care is personalized to tumor size, nodes, and biomarkers, and 2025 surgery cures cancer with smaller operations and better treatments and protects lung function. Thank you very much.
Now it's my pleasure to introduce to you Dr. Benjamin Cooper. Ben is Associate Professor of Radiation Oncology. He's the Director of the Proton Therapy at NYU. And he is also the Site Director for Radiation Oncology in the Cancer Center. So Ben is going to talk to us about newest advances in radiation, perhaps. So Ben, the floor is yours.
Thank you so much, Dr. Shashua. I appreciate the introduction, and thank you all for taking the time out of your evening when there's lots of things you could be doing and spending it with us. So here today, I'm going to talk about some of the advances in radiation oncology, specifically for the treatment of lung cancer. So you just heard Dr. Pass talk about one of the ways to attack lung cancer. As many of you know, there are multiple ways to attack lung cancer, the first being surgery, and this is the surgical robot, which you just saw. The second one you'll hear about next with Dr. Sabari, that's systemic therapy or therapy that goes everywhere in the body. That can be chemotherapy, immunotherapy, and he'll probably talk to you about some of the new exciting targeted therapies. And the last is radiation therapy, which uses either X-rays or other particles to try to damage the DNA of cancer cells and kill them. So I saw one of the questions actually already was, how can we decrease the recurrence rate after surgery? And we'll discuss that in a second as well. So the traditional treatment paradigms for stage 1 and 2 disease, and now some stage 3 disease that's resectable, is for surgical resection. For unresectable stage 3, we do chemotherapy and radiation, and now we do immunotherapy afterwards. And for stage 4 disease, traditionally, it was just chemotherapy, and then we would use radiation only for palliation. If somebody had a symptom that was bothering them from the cancer, like pain from cancer going to the bone, bleeding from a lung tumor, or if the tumor's blocking and part of the lung and they're having trouble breathing, then we would use radiation. But we didn't really use radiation outside of that historically in stage 4 lung cancer, and that is changing. And we're trying to really push the envelope in stage 4 disease with both radiation and surgery to try to give the best chance of long-term disease control. So one thing to help decrease the risk of recurrence postoperatively is a collaboration with my surgeons where we put an implantable radiation mesh. So you could see this mesh here has these gold seeds, and that actually is able to block the radiation and just put it in one direction. And where that can be helpful is if they do one of those wedge resections that Dr. Pass discussed, where they cut out a piece of the lung and put the staple line there, you can put this mesh right on top, and the gold is very dense, so it blocks the radiation. So any of the normal lung around there doesn't get the radiation. It's really just directed right to the tumor. We do this at the time of operation, so when you wake up, you've already had your radiation. So you already have that risk reduction of local control. Another thing we can do for stage 1 disease, and with all of the new physics advances and computer advances and everything else that we've had, is there's a type of radiation that's very high dose. It's very precise. It's called stereotactic body radiation therapy. And this initially was used as a curative option for frail patients who could not get surgery. So potentially a 90-year-old patient that has a history of some heart disease that really wouldn't tolerate anesthesia so well, or a heavy smoker potentially that um, would have issues if you cut out a large portion of the lung. Uh, One of the machines that does this that you may have seen advertisements for is something called CyberKnife. That's basically almost like robotic radiation. This was really a repurposed car building robot that they put the radiation machine on, so you could get lots of angles and really focus on the lung tumor. You could see that red dose there is really just going to the lung tumor, and the majority of the lung is spared if you look at this X-ray, and there's no radiation going to the heart or really to the other lung or anything like that. So this high dose of radiation can cure patients without surgery. And we initially used this just for patients that really could not tolerate surgery. However, we are looking, and Dr. Pass and I participated in a study where we were looking at these patients that could get surgery, but they're at a high risk for a problem after surgery, whether that's needing oxygen or whether it's some other issue. And the patients were actually being randomized to either surgery or to radiation. And this is one of the ways we're trying to push the envelope with some of these non-invasive radiation treatments to really bring cures to patients potentially without requiring a surgery if they are at high risk for surgery. In stage lung cancer, this means lung cancer that usually has spread to the lymph nodes in the middle of the chest, the mediastinum. If they cannot go for surgery, the standard treatment is chemotherapy and radiation, followed by immunotherapy. Now, what can we do to try to advance this? One thing we can do is potentially use something called proton therapy to make the radiation less toxic. If you look on the right side of your screen here, you could see that the proton dose, you can see on the y-axis on the left, 100% at the top, 0% at the bottom. The 100% of the dose is all deposited basically in one spot, whereas the X-rays, they keep going. And that's helpful if you're trying to take a chest X-ray, if you're standing in front of a detector. But if you don't want to give any radiation to the normal tissue here, it's nice to stop the radiation. And you can see a lung cancer plan where they came with the radiation and they were able to give the patient radiation, but stop all the radiation before it gets to this pink structure, the heart, or get to the other lung. Whereas a regular X-ray radiation plan does give some radiation to the other lung and to the heart. So that is one way that we can potentially make radiation less toxic with advanced technologies. A way to potentially make the radiation more effective and try to cure more patients is with something called a radiosensitizer. So some kind of compound that makes the radiation more potent, that really can help give the tumor more dose, but the surrounding lung and esophagus and other things don't get the radiation dose. We have a trial open here with this radiosensitizer through Johnson & Johnson that is a high density core, which basically all that really does is allows for more electrons to be in the vicinity of the tumor, which allows more damage from the X-rays. So you could see here, normally X-rays interact with water molecules and cause some damage, whereas in these tumors that you inject this compound in studies, they see 9 times more damage from the radiation. So you can basically get a higher cure rate at a lower dose, so you can not hurt the normal tissue as much. So this is a very exciting trial that we've treated some patients on, and it's something we're very excited about here at NYU. This is just one of the patients that we treated, where basically you could see they inject this white area into this tumor. This is before the injection. This is after the injection, and we can put it into the tumor and the lymph nodes. And this will hopefully make the radiation kill all of these tumor cells much better. What about other uses of radiation and other uses of SBRT? So what we've really been trying to do as a group, and I collaborate with Dr. Sabari, Dr. Pass, and Dr. Joshua with this all the time, is we're trying to really extend the life of people with stage 4 disease, and in very select cases, sometimes even treat all sites of the disease and hope for a cure. So basically, the way we look at this is if somebody is potentially getting a chemotherapy, immunotherapy, or even a targeted drug therapy you'll hear about with Dr. Sabari, and they are doing incredibly well, everything's responding, but there's one spot that's just sort of hanging around. We'll try to use radiation to kill those cells and and that way you could stay on the therapy that you're on and you don't have to change to a second or third line therapy. So we're working on ways to figure out the best way for patient selection, and often we'll use surgery in this setting as well. So that's how we're really moving radiation from just trying to help a symptom to really going farther for cure and disease control. Another thing we've studied here at NYU is trying to use radiation in combination with those immunotherapies that Dr. Sabari is going to talk about, I'm sure, and Dr. Pass is going to talk about, and using drugs to help the immune system fight the cancer. So we did a trial where we used a special drug that works on the immune system with multiple different sites. And we saw that over time, basically, there was more of an immune response in these patients that got the drug with radiation. So by combining radiation as almost a vaccine where you kill the tumor cells, the little tumor cells have their proteins released, and then your immune system can gobble them up and then go try to find the cancer cells elsewhere, similar to whenever you get a vaccine in your arm, it usually has some of the dead virus. Your immune system sees the virus, and then you're protected with antibodies against any further infections. It's the same idea. We're trying to make the radiation a vaccine, essentially. And those are really the main things I wanted to talk about today, and I'm happy to address some more questions in the Q&A.
Now, I'm going to introduce you to Dr. Josh Sabari. Josh is assistant professor in the Department of Medicine. His office is next door to mine, so I talk to him every day. Josh is the director of the High Reliability Organization Initiatives of the Perlmutter Cancer Center, and his research focuses on biomarker development and clinical trials and targeted therapy. And so he's going to tell us a little bit about what's new in that area in terms of breakthroughs. And certainly there's been much excitement. So Josh, again, go ahead.
Thank you, Dr. Shashua. Thank you to everyone for joining us this evening, and really a task to talk about, updates on clinical trials at NYU, focusing on lung cancer breakthroughs in this space. We heard a lot already from Dr. Pass about surgery being utilized in early stage disease, and we also heard a lot about the technological advances of radiation therapy. I'm going to focus more on patients who have more advanced disease. Here are my disclosures. So we have a large group at NYU. You've heard from Dr. Abe Shashua, who leads our thoracic medical oncology group. But in Manhattan, we also have Dr. Elaine Shum, Dr. Raj Velmaswamy, myself, Dr. Salman Punakar. We have a presence out in Long Island as well, NYU Long Island, with Dr. Jeff Schneider and Dr. Marissa Ribstein, as well as more recently in Brooklyn at NYU Brooklyn with Dr. Alyssa Sokoloff. So really an integrated network. And these are folks predominantly treating thoracic malignancies, so expertise in the lung cancer space. So we've heard already that lung cancer is quite a heterogeneous disease. There are multiple different types, most commonly non-small cell lung cancer, but we'll also touch on a more rare entity called small cell lung cancer this evening. It is the second most common lung cancer or cancer diagnosed in the United States. Most commonly is breast cancer and prostate cancer in men and women. But lung cancer actually has the highest rate of mortality. But as we showed from Dr. Pass's data, is that the 5-year survival data is improving dramatically. So when Dr. Shashua started in practice, he mentioned we really only had chemotherapy. But now we have novel immunotherapies, we have novel targeted therapies, and we also have better modalities to diagnose lung cancer early. And something that I want you to understand tonight is that if we diagnose lung cancer early, the rates of cure is higher or are higher. So 30% of people are alive now with lung cancer at 5 years. And this brings up a whole other question of how do we care for people who have had lung cancer who are now doing well? So when we think about lung cancer, particularly late stage lung cancer, we want to look at genomics or biomarkers, and we'll talk about doing sequencing in the tissue and the plasma. We'll also talk about PD-L1, which is a marker on the surface of cancer cells that will allow us to predict who will respond well to immunotherapy. So before going into some of the later stage setting, let's talk about some of the drivers. So there's really a revolution in the lung cancer space. This is a pie chart of all the different driver mutations that have been identified in lung cancer. Over 20 different mutations, 11 of them have matched targeted therapies that are approved. And this list continues to grow day by day, month by month. So again, there is a lot of hope in the diagnosis of lung cancer. I want to point your attention to one specific group, and there was already a question about why are we seeing lung cancer in never smokers? My colleague, Dr. Elaine Shum, asked this question in young female Asian women who are never smokers. If we did a low-dose CT screening, could that increase the detection rate? And those patients would then go to the operating room with Dr. Pass and others and be cured of their lung cancer. And what she did is a study of 1,000 women who had low-dose CT scan. We also did concurrent blood testing to try to understand the biology of this cancer. And what she found in her study was quite astonishing, that 1.3% of women in the trial with a low-dose CT were identified to have a lung cancer, most of them EGFR, which is one of the most common driver mutations. The reason this is so astonishing is because if you look at the NLST trial, the trial that Dr. Pass cited, which is in patients who previously smoked, the rate of detection was only 1.1%. So it's an interesting thought. Should we be screening younger patients? Should we be screening patients who never smoked? A lot more work ongoing in this field. I want to pivot to patients who have stage 4 cancer, cancer that started in the lung and learned how to travel elsewhere in the body, and specifically here focusing on some of the updates in targeted therapy. So we looked at this pie chart and we see that there are many different mutations that are seen in cancer. We're going to focus on a rare mutation first called HER2, HER2, which occurs in about 2 to 4% of patients with non-small cell lung cancer. And there's a complex mutation, but generally when you have an abnormality or a mutation in a gene, what it does is it tells the cells to continue to grow. And what we try to think about is how can we block that signal with medications, with pills. So for HER2 mutations, for very long, we have not had any true targeted therapies. We started studying this medicine, zongertinib, a highly selective HER2 inhibitor. And what we're showing here is that this medicine is more selective, more precise than a lot of the other HER2 targeted therapies that we've had in the past. And when we ran this clinical trial, started in 2022 here at NYU and was just FDA approved in August of 2025, what we saw at 120 milligrams, we saw robust responses. Each line here on this graph is an individual patient, and the downgoing bars are the response or regression in the tumor. So 71% of people with HER2 mutation receiving this medicine had profound response to therapy. And not only is it a short response, but people have durable or long-term responses. We're looking at a swimmer's plot here. Each patient is in a lane, and you can see the duration of time that people have remained on therapy. I myself, Dr. Shashua, Dr. Shum, and others have patients who are on these treatments for 2-3 years now. So we're seeing durable, long-term responses. This is actually a patient of Dr. Shashua who was referred to me in probably early January of 2024. And you can see her CT scan on that left-hand side there with diffuse, what we call lymphangitic carcinomatosis. In more simpler terms, there's cancer spreading through the lymph channels. And after 6 weeks of therapy, you see a dramatic response in the right chest, a dramatic clinical improvement in her symptoms. And most recently, 22 months out, her scan continues to look very good. Moving off of HER2, which is a rare mutation, I want to focus on KRAS, which is a very common mutation, occurring in about 30% of our patients with non-small cell lung cancer. We've been the sort of lead sites for accrual in some of the FDA-approved therapies for KRAS G12C, one of the more common KRAS alterations, with approvals of adagrasib as well as sotorasib. And we're also leading the charge at NYU for many trials in the frontline setting, people newly diagnosed with KRAS mutation non-small cell lung cancer. This is a study being led by Dr. Velmaswamy, specifically looking at a novel agent, BBO-8520, which impressively has activity even after some of the conventional therapies stop working. So show you some of the preclinical work in this setting. We see here that BBO-8520 has more potency than sotorasib and adagrasib. And in the first 10 patients that have been evaluable, remember, each one of these lines on this bar chart are in the size of the individual patient's tumor cells. You see a dramatic regression in the size of the tumor. So we've seen multiple responses on trial, and this is one of the more exciting novel KRAS inhibitors in the non-small cell lung cancer space. We also heard about small cell lung cancer. So small cell lung cancer is a different biology. We've been talking about non-small cell lung cancer so far. That occurs in about 85% of patients. Small cell lung cancer is quite complex. This is a disease that is seen exclusively in people who have a history of smoking, and we see very common, genomic mutations in these two genes called P53 and RB1. And to make the story sort of short, we have not been able to target them well. Dr. Kwok Wong and Dr. J.T. Poray and others, colleagues at Memorial Sloan Kettering, have worked diligently to try to better understand this disease, and using some transcription factor analysis, trying to understand different subtypes, we have now started to develop novel therapeutic options in this patient population. So the data I'm going to show you here is probably the most practice-changing data we've seen in small cell lung cancer, a recalcitrant disease where therapies really have not improved for the past 40 years. We are now starting to see light at the end of the tunnel. So DLL3 is one of these factors that is expressed in small cell lung cancer. What I'm showing you here is that if we measure this biomarker, DLL3, you see that it's highly visible or highly expressed in this type of cancer. We've worked with a company here, Amgen, developing this medicine, tarlatamab, formerly known as AMG 757, and it's a very novel compound. It's actually an immunotherapy, different from some of the targeted therapies we had talked about. This is a bispecific antibody. So it's an antibody that has an arm that blocks DLL3, which is seen on the small cell lung cancer cells, and it also has an arm that blocks something called CD3. Now, CD3 is expressed in immune cells, and by using an antibody that targets DLL3 and CD3, we bring immune cells into proximity to small cell lung cancer cells, and we see profound activity. So we were participating in this phase 1 study of tarlatamab. Again, the responses here were low, about 30%, but what we saw was durable response. And my colleague, Dr. Salman Punakar here, led the trial. This is the second-line study for tarlatamab versus chemotherapy. And this was recently FDA approved and likely will move into the frontline setting in the near future with ongoing clinical trials in this space. Here's a patient of mine that I treated, and I'm pointing out on the left a lymph node in the middle part of the chest. Lymph nodes help fight infection, but we know that cancers can travel or spread to lymph nodes. So prior to treatment with tarlatamab on the left, and on the right-hand side, you see after 12 weeks of therapy, a dramatic response with regression in that lymph node. The patient also had dramatic response in a right upper lobe mass. On the left-hand side, you see this large tumor in the right upper part of the lung, and 6 months post-tarlatamab with ongoing response in the right upper lobe. And lastly, this patient also had very nice response in the CNS, in the brain. It's important for us to monitor the brain closely, and here you can see a lesion in the left cerebellum. The cerebellum is responsible for gait and motor coordination with a really deep and nice response to tarlatamab. So with that, I want to thank everyone for their attention and looking forward to the questions. I'll turn it back to you, Dr. Shashua.
Thank you, Josh. That was incredible. Thank you. So now, Dr. Sturman, you have to top that. Dr. Sturman is a professor of pulmonary and critical care medicine at NYU, and I've had the pleasure of working with Dan for many years. So Dan, please take it away.
I'm Dan Sturman from pulmonary medicine, and I'm going to give you a little bit of a perspective from the pulmonary medicine and the interventional pulmonology approach to lung cancer and some of the advances that we're making together with our colleagues in the field. So these are my disclosures. So from a pulmonologist perspective, we still have a global health crisis that we're dealing with in lung cancer, despite all the advances that you heard from our colleagues. It remains lung cancer, the number one cause of cancer death in the United States and worldwide. Still, despite lung cancer screening, majority of patients still present in advanced stages where cure, especially with surgery, is very challenging. that we've shown that survival can be improved with targeted immune-based therapies, as you've heard from Dr. Sabari. And you've heard from my colleagues, each of whom has mentioned that lung cancer screening is absolutely crucial for those in high-risk categories, but even for those who may be in categories that we can't necessarily classically categorize as high risk. And increasing numbers of non-smokers are diagnosed with lung cancer, which makes screening even more complicated, as you heard, related to the FAN study by Dr. Schum. So how have we transformed lung cancer care? You've heard from Dr. Pass that surgery remains our best chance for cure in early stage disease, often in combination with chemotherapy and radiation therapy. That our targeted therapies that have been developed, such as that Dr. Sabari has illuminated, have altered the landscape for all stages of cancer, lung cancer. And immunotherapy is an integral part of the standard of care for lung cancer patients, often in combination with chemotherapy and with surgery and with radiation therapy. So what else is coming down the pike? What I'm going to tell you about in the next few slides are areas of investigation in a novel type of treatment, which is delivery of therapy directly into the lung cancer itself. So why would we do that? Why would we deliver therapies into the tumor itself when we could otherwise give a pill or giving something by vein? One is that you, in theory, can achieve much higher local concentrations to increase the efficacy of whatever the therapeutic is that you're injecting directly within the tumor or in the lymph node. You can potentially lower the systemic concentration by reducing the amount of bloodstream concentration of the specific agent, and thereby reduce the toxicity. You can also target metastatic disease directly in the lymph nodes by delivering the therapy directly into the lymph nodes themselves, or by injecting into the tumor and having the lymphatics drain the therapeutic into the regional lymph nodes. And again, these approaches, as you've heard before from some of the other techniques, including radiation therapy, are the concept of vaccinating patients against their own tumor and against the antigens that are present in the patient's own unique profile. And there's obviously a potential to combine local therapy with systemic therapies, with surgery, with radiation therapy. And I think this field is going to emerge in the next decade as one that's going to be incredibly exciting. So you can inject a variety of different approaches directly into the tumor. You can take chemotherapies that you otherwise would give by vein and deliver them directly through novel endoscopic technologies into tumors and lymph nodes. You can inject a variety of immunotherapies, and I'll be talking about one form of immunotherapy called viral immunostimulatory gene delivery in a few minutes. You also can inject viruses which replicate selectively in tumors called oncolytic virotherapy, and even cell therapy, which you may have heard about before, can be delivered directly into tumors and lymph nodes and may eliminate some of the toxicities that are seen with systemic delivery of cell therapies. But in addition, you could deliver energy directly to the tumors using percutaneous or bronchoscopic approaches. And at NYU, we're very interested in a number of these approaches, including freezing tumors with what's called cryotherapy and delivering electrical current to the tumors using something called pulse electrical field. So we have developed a concept at NYU called bronchoscopic cryoimmunotherapy. So this is the idea of delivering a small probe directly into the tumor, ideally at the time of a standard of care bronchoscopy or potentially a needle biopsy, to freeze a portion of the tumor. And the idea is to freeze a portion of the tumor to liberate tumor antigens and initiate an immune response both locally in the tumor as well as systemically. This can be applied directly into tumors using a variety of different endoscopic approaches. Here you see our colleagues in our interventional pulmonary operating room using robotic bronchoscopy to deliver a cryoprobe directly into the tumor. And when we've shown here that when we deliver the cryoablation directly into the tumor, we can significantly increase CD8 T cell infiltration into the tumor microenvironment. You'll see that we conducted a first-in-human phase 1 dose escalation clinical trial of bronchoscopic cryoimmunotherapy in patients with advanced lung cancer. We saw absolutely no adverse events, no bleeding, no pneumothorax, no pneumonias. We saw that by doing the cryoimmunotherapy, we induced immune responses, both generally as well as tumor-specific, compared in the blood specimens pre compared to post. And we plan a follow-up study in early stage patients prior to surgery to see if we can improve on outcomes of surgical resection. I mentioned pulse electrical field treatment. This is a novel delivery of electrical current through a device, literally a needle that's put directly into the tumor, either under CT scan guidance by radiology or directly through a bronchoscope used in our interventional pulmonary operating room. Here is a patient on the left-hand panel with a cancer in the left upper lobe, the solid lesion. This was treated with pulse electrical field and then subsequently with radiotherapy with a complete response. And this turned out to be a small cell lung cancer that was completely cured without chemotherapy or any other immunotherapy for the specific cancer. And we studied this together with Bill Moore from thoracic radiology, in which percutaneous pulse electrical field was delivered to patients with stage 4 non-small cell lung cancer refractory to all forms of therapy. And in a comparison to a matched cohort of patients also with refractory stage 4 lung cancer, those who received PEF had a dramatically improved overall survival, suggesting that there's a significant immunological phenomenon induced by pulse electrical field that we hope as groups, as our lung cancer group here, to study together going forward in the future. We're also studying, as I mentioned, a variety of immunotherapies that we can inject directly into the tumor. This is a national study at 12 centers nationwide that was co-led by myself, but as I mentioned, at multiple academic centers around the country, in which we injected a modified cold virus that could be activated directly into the tumor by taking an oral drug, valcyclovir or Valtrex, a FDA-approved antiviral therapy that induces both local and systemic anti-tumor immune responses. So this is my colleagues in our interventional pulmonology operating room, Dr. Drew DeMeo and Dr. Isaac Laniato, injecting using endobronchial ultrasound this genetically modified cold virus into a tumor mass adjacent to the trachea in a patient with advanced refractory non-small cell lung cancer. So we presented this data at our World Lung Cancer Conference both last year and this year, and showed that a significant improvement in survival compared to historical controls in patients who had already failed frontline chemoimmunotherapy, and significant numbers of patients who had responses beyond where the injection was done, so-called abscopal responses. So we will be leading a global phase 3 clinical trial using this intratumoral viral immunotherapy in 2026 in patients with advanced non-small cell lung cancer who are refractory to frontline chemoimmunotherapy. Very exciting. So the question is, what is the future of this therapy? Can we impact both local and systemic disease while decreasing toxicity? So intratumoral therapies enhance cancer treatment through local and systemic immune activation, essentially this so-called in situ vaccination. That recent advancements in robotic bronchoscopy, cone beam CT have markedly improved the feasibility, accuracy, and clinical integration of these novel technologies. The novel ablative therapies, such as cryoablation and PEF, may, for a small subset of patients, replace surgical resection, but for others, offer unique synergies with surgery, radiation, and immunotherapy to allow another arm of multimodality therapy for these patients. And these novel agents, combined with the rapid tissue diagnosis capabilities of artificial intelligence and advanced precision imaging, will enable intratumoral therapies, I hope, to be a key component of future cancer therapeutics. So this coming July 2026, we're going to be hosting an international symposium exploring these novel intratumoral therapies in lung cancer and the ways that they can integrate with other therapies going forward in the future. We're incredibly excited for where this field may go in the future. So thank you very much for your time, and I appreciate your patience and your consideration, and I'm happy to answer any questions you might have.
All right. Great. Thank you all. Just want to point out, I think from everybody, I mean, there's been a series of incredible talks here. It really does take a village to treat somebody with lung cancer. And I think, as you see here, it's a combination of medical oncology, radiation, surgery, interventional pulmonary, and that's how you're going to get the best outcomes for your patients. So I think that's a very key thing to success. Okay, so now I'm going to go through a series of questions. Harvey, for you, are there new surgical options if the tumor is near the heart or the spine?
Absolutely. For the spine, you can have combination operations with the either neurosurgeons or the orthopedic surgeons that you can go ahead and actually remove a portion of the spine and then replace it with materials. And at the same time, locally, hopefully with negative margins, remove the tumor so that then you would enforce that the spine is going to be free of tumor, and using other materials is going to heal properly and the patient can recuperate. With regard to tumors of the heart, I think that if it's involving the heart, then I think that we would get in contact with our friend, Dr. Sabari, and we would think about what are the systemic types of therapies that could be given preoperatively to somebody like this, who would be able to do have a preoperative response and see if then after that response, a smaller portion would have to be removed if you're going to have to remove a portion of the atrium or the ventricle. But certainly those operations in which they are involving the ventricle or the superior pulmonary vein have been in the past done either with or without bypass, and patients have done very, very well.
Thank you, Harvey. Dan, why are lung cancer rates increasing in never smokers? And are they different cancers?
Well, it's a great question. And I think that the answer is we don't know all the answers. I think we have a lot of suspicion. There's some data from the Cancer Research UK group, Charlie Swanton and his team, that air pollution and other particles in the air may have a significant impact in combination with genetics and other factors. So I think that this certainly may play a role in women in Asia who are exposed to a variety of cooking fumes and other particles that may predispose them to developing lung cancers. But I think that we have to elucidate this because of the high number of lung cancers occurring in non-smokers, especially non-smoking women. So many answers to come, many questions, and we don't have them all.
Josh, advances in targeted therapy are amazing. This particular person has been on selpercatinib, and it was advised early on that the body develops resistance 2 years later on average. Is there anything that can be done to combat this resistance?
Yeah, it's a great question. So selpercatinib, formerly known as LOXO-292, has been a revolutionary medicine in people with RET rearranged non-small cell lung cancer. And, resistance is inevitable, right? That's what we're taught, but we can get ahead of it, right? So by using liquid biopsy or circulating tumor DNA, we can monitor patients and we can understand if resistance is emerging. And, in the lab, we are able to even model resistance mechanisms in animal models and think about novel therapies that can overcome these resistance. So there are multiple agents in the lab and in the clinic looking at overcoming resistance already to selpercatinib. But clinically, I would remain on therapy for as long as the medication was working, and as long as you're feeling well and there's no evidence of any clinical progression. If there's progression in the blood or progression by ctDNA, I think that's early on going to be helpful for us to think about next treatment options for you. But I want you to be rest assured that the medication is working and your doctors are doing everything right by you.
And one thing that we could do if it only progresses in one or a couple spots is try to eliminate the cells that have developed the resistance and are progressing with radiation or other modalities like that.
That's a great point. We do always try to squeeze as much as we can out of each medication. So referring to Ben and other radiation oncologists is definitely an option.
Ben, is radiation safe for older adults or those with other health problems?
I would say yes. Probably there are some health problems that I get more concerned about radiating the lung, like interstitial lung disease and things of that nature. But age alone, I'm not discriminatory. I have a 100-year-old patient on treatment for radiation right now. My oldest is, I believe it was 106, and my youngest has been, 12 months. So it's the whole spectrum can get treated.
Harvey and Dan, I have two questions on mesothelioma, which we did not speak on, but maybe we can spend a few minutes. Harvey, what is mesothelioma?
Mesothelioma is not lung cancer. It's a separate entity, which is actually caused by asbestos. And exposure to asbestos does things to the cells in which they become, let's just say, immortalized, and the cells change from normal to a cancer cell. Mesothelioma grows and usually spreads within cavities, usually within the pleural cavity or within the abdominal cavity. It's a very difficult disease to treat. We haven't done as well with mesothelioma as we've done with lung cancer. The role of surgery is being questioned, but certainly I still think there's a tremendous role for lung cancer, for surgery in mesothelioma, and combined with new immunotherapies, the results are promising, especially if you give it like we've talked about before with neoadjuvant therapies. So I think that the disease is such that it's difficult to find And usually patients present late and older, because it's been around a while and it's asymptomatic. But you also have to be careful in a certain subset of patients that have multiple malignancies in families, because mesothelioma is associated with a gene also, and it's called BAP1. And that gene, actually, if it's in your germline, if you're born with it, if you're in all of your cells, and it's mutated, you have an increased propensity to develop mesothelioma. But the mesothelioma is different. It's less aggressive, and it comes in families. So the diagnosis in patients who have family relatives with mesothelioma, maybe you should do germline testing to make sure that the kids don't have it, or that it's in families, and you can try to monitor them very carefully.
Okay. Dan, I think the question is for you. Can you see on a CAT scan if a nodule looks like it may or may not be cancer?
I think you can. I think that part of what we all do in our lung cancer team is pattern recognition. And I think that when we have a question, we often bring it to our multidisciplinary tumor board on Friday and ask what people think about a specific image. And so I think it's really important for patients to understand that we work as a team. We don't work individually. And we work closely with our thoracic radiologists who aren't represented today, who are excellent here at NYU Langone. And I think there are characteristics, and I think that there are opportunities to use CT scans and using artificial intelligence to be able to actually divine that even further, to be able to look at nodules which may be so-called indeterminate nodules and have a better idea about whether they're likely to be malignant in the future. So I think that the availability of artificial intelligence to query lung nodules and give us a better idea about their propensity for malignancy is something that probably is going to be available in the next few years.
Okay. Josh, you didn't talk about mRNA vaccines or vaccines for lung cancer in general. Maybe you could talk about that. Where are we with those?
Yeah, I mean, I think there's been a lot of excitement about vaccines, particularly in the early stage setting, in the neoadjuvant space. And neoadjuvant just means, some form of therapy before surgery. And why is vaccines very exciting in that setting? Because we get a piece of the tumor right up front. We're able to then potentially guide specific therapy to the patient. We then resect. So we have a window of opportunity to understand if the therapy's worked. And we're able to then give therapy on the back end as well. So in the metastatic setting, people with stage 4 lung cancer, by and large, some of the vaccines have been less effective. Remember, a lot of our patients are having prior PD-1 or PD-L1 inhibitors. Those are the standard immunotherapies. And it's really hard for vaccines to elicit an immune response when someone's tumor is growing on or after the conventional immunotherapy. I think in the early stage setting, both neoadjuvant before surgery, as well as in the adjuvant setting after surgery, there's a lot of hope and a lot of excitement remains with vaccines. And studies are ongoing here at NYU Langone Health at this time.
Is AI being used in lung cancer treatment? I think, Dan, maybe you could tackle that one.
I have an answer as well.
All right.
Ben, why don't you start and then I'll follow up.
Okay.
Yeah, so I actually have a slide on this.
Even better.
Yeah. Let's see, is everybody seeing this okay?
Yep.
Yes.
Yeah, so this is a trial we're thinking about, opening here at NYU. It's basically we're looking at using AI to direct our dose planning and dose recommendation. So by really having the computer analyze, millions of CAT scans and all the data that you have in these CAT scans to really determine the best way to target the radiation, the safest dose, the most efficacious dose, when to give a higher dose because you're less likely to get a response, when to give a lower dose because you can give a lower dose and it's safe, and everything in between. So this is just one of the many ways where we are trying to integrate AI into our treatment repertoire.
Okay. Dan?
I'll just mention in our lung cancer screening program, where we take high-risk patients, typically patients between the ages of 50 and 80, who are either active smokers or quit within the last 15 years. We're trying to take their CT scans and run them through an algorithm called Sybil, which was published out of the Massachusetts General Hospital several years ago. And this enables us to take all of the pixels from a CT scan, not just from the lung, but outside of the lung itself, incorporate all this data, put it through a machine learning algorithm, and then determine a probability that the individual will develop lung cancer, either in a nodule, which is visualized on the lung cancer screening scan, or even remarkably on a scan that looks otherwise normal. So the ability to give a probability for the development of lung cancer in an otherwise normal lung cancer screening scan is absolutely remarkable. And the technology has the capability of pinpointing where that lung cancer may develop in the future, even with the absence of an abnormality. So we're looking at the simple algorithm in our thousands of patients who have been through lung cancer screening and trying to correlate that with what we've ultimately found by following these patients longitudinally.
Okay, I'm sorry we're not going to be able to get to all the questions, but Josh, I think why don't I give you the last question? In patients who are in immunotherapy, stage 4 and progressed, what are some of the treatment options?
There are so many options in the clinic right now under investigation in clinical trials. There are novel immunotherapy combinations that are being developed. There are also antibody drug conjugates that are being developed. These are smart chemotherapies that are conjugated to an antibody, as well as many targeted therapies. So the main question I would ask is, what is the biology of the tumor? So once somebody is progressing or having growth on chemotherapy and immunotherapy or immunotherapy alone, we want to understand what are the biomarkers in that cancer. And there are so many different options available. There are also conventional chemotherapy options that are available that are not wrong, but really the future is very bright. And I think enrolling in a trial in the second line is important, not only for you, your family member, but also for people who may come in the future.